there, welcome back to Cycle Power Summit 2019. I'm your co-host, Melissa Buchan. This session is all things PMS, premenstrual syndrome. Now, according to the National Center of Biotechnology Information, most girls and women experience some degree of PMS. And 20 to 40% of women experience severe PMS that affects their daily lives. And up to 8% of women experience extreme symptoms, particularly psychological problems that prevent them from going on with their daily lives. Now, this is known as premenstrual dysphoric disorder, PMDD. Our expert is Dr. Jeremy Kalamarides from Austin, Texas. Dr. Kalamarides is the medical director of the Vitae Clinic and medical director of St. John Paul II Life Center. He serves on the Diocese of Austin Pro-Life Advisory Council and is a certified fertility care consultant and practitioner. Dr. Kalamarides' main interests are minimally invasive endometriosis and PCOS surgery, prevention of miscarriage, treatment of PMS and PCOS, and holistic care of pregnant women. Now, I have a fantastic fun fact for all of you. Prior to going to medical school, Dr. Kalamarides worked at the Pope Paul VI Institute for the Study of Human Reproduction in Omaha, Nebraska, where he helped his mentor, Dr. Thomas Hilders, complete the research for the text, The Medical and Surgical Practice of Naprotechnology. Now, this medical textbook is the definitive guide for naprotechnology's approach to women's reproductive care. Dr. Kalamarides, welcome to the summit.
Thank you very much for inviting me. It's a pleasure to be here.
Yes, you all. Okay, so you are one busy guy. And, I get so very fired up in connecting with dedicated medical professionals like yourself who are just working so diligently for women's health care. Mm-hmm. And so today we're talking all about premenstrual syndrome. And so, I have a feeling that most of the women who are tuning into this session are going to be very interested in this topic. Now, as a physician, I would really like to hear about your concerns when a woman comes to you with a complaint of PMS.
Yeah, my concerns are, first of all, how it's affecting their lives and their family and their work. But also there's concerns beyond just the actual symptoms she's having and, whether or not that's actually affecting her health for the future. And part of that could be making sure that they're not actually in a depressed state or having anxiety that's inhibiting them. That needs to be treated all the time, and differentiating premenstrual syndrome or premenstrual dysphoric disorder, and then giving them the right treatment that's going to be cooperative. Lots of times women will come to our office and they'll say they've actually sought treatment for what they felt was PMS, but either they were ignored or they got treatment that was ineffective. And sometimes they've tried several treatments, but they haven't sought cooperative therapy.
And can you speak to that? What do you mean when you say cooperative therapy?
This is very interesting. So first of all, the normal, we haven't gone over all the symptoms, and we'll do that in just a few minutes. Okay. But as far as the treatments go, right off the bat, the normal typical OB-GYN treatments for PMS are first to put people on oral contraceptives or hormonal contraception that's going to basically replace all their hormones. It's kind of like the doctor's tools are only to say to the patient, well, your hormones in your system is so messed up, we're just going to replace your hormones. And so they give them artificial hormones of estrogen and progesterone combinations that are not really, certainly not bioidentical, or isomolecular is a better term. Mm-hmm. And therefore they don't work cooperatively to help the body work better. Instead, they just replace what's going on, and the patient does get usually some relief from that, but it's not, it may have other side effects. Lots of times the patients don't like how they feel with these other artificial hormones. So a cooperative way of treating them would be to actually treat the time and the actual symptoms and the underlying cause of what's going on that's causing the PMS. Other treatments, and this is just a very quick summary, but the I think it's the in the UK, the surgeons there came up with basically a systematic way of treating women with PMS, and they just kind of did a nice review. But it's to me, it sounds kind of barbaric still, because they go with the normal treatment of giving people oral contraception, and if that's not working, they'd work with selective serotonin reuptake inhibitors, which is a psychotropic medication. It's for depression, and these have been found to be somewhat effective, and for some people that's actually a very good treatment, and it's very safe too. But they're not quite as effective as some of the NAPR technology treatments we're going to get into. After that, everybody knows that some of the anti-anxiety medications actually do work very well for PMS, but because of their addictive qualities, physicians really want to try to avoid that for their patients. And most patients who sometimes a patient with PMS actually is desiring to achieve pregnancy. And well, these medications aren't compatible with achieving pregnancy, like Xanax. It works very well for treating some severe PMS, but we don't want to give that to a patient who's actually achieving pregnancy or pregnant. Once people are pregnant, of course, they actually do get a huge relief from their PMS symptoms, because they're not dealing with a cyclic variation in the hormones, which goes to what actually causes the PMS. Mm-hmm. Finally, there's a couple of treatments. If the Xanax doesn't work, then they'll go on to treat with Lupron, which is gonadotropin releasing hormone. And this actually just gives the woman a chemical menopause, and it lasts for a period of time, either a month at a time or 3 months at a time. But then you get symptoms of menopause instead. And if that doesn't work, actually, for severe PMS, the treatment is actually hysterectomy with oophorectomy, making the woman not able to bear children anymore. And that just seems like, wow, that's so extreme. Mm-hmm. And yet they haven't really hit on anything that is a cooperative type of way of treating the patient. So what is PMS? You know, PMS is really symptoms of feeling increased emotionality, fatigue, irritability, insomnia, breast tenderness, bloating, increased feelings of depression and anxiety, and carbohydrate cravings. I think I've hit on, and I think I mentioned bloating. So it's that those are the symptoms really that we recognize very often as NAPR technology physicians and practitioners. We can really say, okay, if you just even have one of those symptoms occurring at least 3 days before a woman's menses, then and usually after ovulation, mm-hmm. that's likely PMS. And especially if it's affecting the woman's activities of daily living, that's something that needs to be treated. Premenstrual dysphoric disorder, as you touched on, is really if you have 5 or more symptoms. And I find that lots of women have 5 or more symptoms. Sometimes they have everything. And when I sometimes I'll ask women, and you know, a lot of women they're very strong and courageous people, but often they're not too likely to admit that they're feeling those symptoms or that it's affecting them. If their partner is there with them at the visit, lots of times I look at them as a barometer of how the woman is actually doing. And mm-hmm. sometimes they will say like, oh, you have these symptoms, you know, I see it all the time. And then they realize, oh, I guess it is affecting me. Lots of times they'll be more forthright about what's going on. And, you know, again, when a woman sees that something's affecting them and they actually have a moment to say and express themselves in an open way with someone who's listening, then we're ready to listen and really help and treat that person. So it's just sometimes you just ask the patient, do you get the answer? And that's what we do a lot with NAPR technology.
Yeah, so that's fantastic that you're talking about you really using a relationship as a barometer and really digging into helping a woman understand when she's experiencing these symptoms. In the summit, we're talking a lot about the power of charting your cycle and charting it well so that you can have a good record of what's going on. So do you encourage, or I'll maybe rephrase that. When you are working with a patient who is struggling with PMS, how important is it for them to chart their symptoms?
This is where we get into charting your symptoms of PMS, and especially in our system of with the Creighton model fertility care system, the practitioners often pass out a PMS symptom tracker, and it's really a great tool because we can see, especially in relationship to the actual Creighton model chart, when the patient's symptoms come and go. And with PMS and PMDD, those symptoms usually resolve after the woman gets her menses. In fact, lots of times we'll be like, oh, if I can just get my menses, my period, then I'll feel so much better. And this is very interesting. So you're right. By charting, the woman can identify when she's ovulating, and they do that so accurately. And this is really a blessing for us, the practitioners, and the doctors, because it's a very simple way of doing it. They don't have to use any devices or any kind of expensive testing equipment. There's no LH kits. This is way more accurate. It's been proven if you just chart the woman's mucus cycle, find the peak day, then we can start treating women. We can actually do testing much more accurately than anybody. We can figure out all kinds of problems, not just PMS, but also, you figure out the cause of unusual bleeding. We can get to the bottom of what is exactly going on for this woman's hormones during their luteal phase, which corresponds to the post-peak phase extremely well. And this is where we talk about cooperative medicine. Yeah. So specifically in this system, we'll see patients who have difficulty with that irritability and the fatigue, and it hits them very hard right after ovulation usually, and then it'll continue, and sometimes it gets worse. If we see that, and then we can know, okay, let's do some testing. Sometimes in some cases I'll go right to treatment, but most of the time I will do some testing to see what their progesterone and estrogen levels are, especially with the luteal phase analysis that we do through NAPR technology. So we'll take serum levels of progesterone and estrogen on peak day +3, 5, 7, 9, and 11, and we'll actually map out what their progesterone is. This is really funny, and it's a little side topic, but I think it's really important. I explained it in 2017 when I was talking about recurrent miscarriage, and the only known treatment for recurrent miscarriage that really works is progesterone. And this is basically, there was a great article about this just last year, but it's been a kind of culmination. Finally, people are really saying, like, yeah, this is really the deal. It's not the only cause, but it's something that the woman can treat. And part of that is some women have these luteal phase deficiencies, but there's an argument that they don't actually really exist, and that's not true. We measure and we see these luteal phase deficiencies often in women who are experiencing PMS, unusual bleeding, and recurrent miscarriage. And because we do this multiple hormone check, we actually get a curve of what's going on, their progesterone throughout the luteal phase. Checking just one time on day 21 in the cycle is actually erroneous. I mean, most women do not have a perfect 30-day cycle, and most women do not ovulate on day 14. It's been shown that about in the past, women ovulate on day 13 like regularly in about 13% of cycles. 13% of women, that is, will ovulate regularly on day 14. And only about 20% of women have like a 30-day cycle every month.
Yeah.
So there's a lot more women who have some variation. Either they are ovulating earlier or later in the cycle. Maybe it's a mix.
Mhm.
And with the Creighton model fertility care system, you finally get a way of identifying when the woman's ovulating very accurately every cycle. And because the charting is done in a prospective manner, that particular woman will be able to know in that particular cycle, of course, when she's fertile and when she's not, but also know exactly when she's ovulating in that cycle. And in cooperation with her practitioner, even with the regular cycle, she can really identify what's going on and then treat herself in a cooperative fashion by giving her the medicine she needs at the right time in the cycle. That's fantastic. That is really, this is something new and revolutionary that I think if we got the word out about this, and even just this particular subject, I often think like if I just wanted to close up shop and not do surgery, and I just wanted to treat PMS all day, I'm sure I could find enough patients and do that.
Oh,
And
absolutely.
they would be all super happy. It's amazing. So this is, we just need to get the word out more about this. And it's a little work.
You're right. And you really opened up my eyes and I don't think I've heard of it, but hearing it from you saying that the hormonal birth control is the number one tool used by the majority of physicians for treating PMS. And we know that it doesn't work as well as progesterone. So it's really allowing women to know the signs of their body. And then, ladies, if you're listening to this, cycle targeted progesterone therapy works wonders. But it's you taking the initiative to chart your cycle, learning how to chart it well, and then finding a doctor who will work with you in that cooperative treatment. So Dr. Kalamarides, you mentioned that there are, the underlying reasons. So when you take something like hormonal birth control for PMS, you are not getting to the underlying reasons. And so you've talked a little bit about that, but do you see that there's a pretty common thread that when you're experiencing PMS, there's usually a correlation with some type of luteal deficiency and insufficient progesterone production?
Absolutely. And everybody knows that they feel it during this particular time in their cycle. So it must be a hormonal problem. There have been studies in the past that showed that women had lower serotonin levels who experienced PMS. And that's where the whole treatment started with using Prozac to help treat especially this new premenstrual dysphoric disorder. And because some of those women were at risk for developing a depressive episode, psychiatrists really grabbed a hold of that and said, okay, well, we can treat this with these selective serotonin reuptake inhibitors and help increase that serotonin. That's great. But we've really found with studies with nanotechnology that treatments that are cooperative and timed appropriately with progesterone actually work. There was a meta-analysis back in 2001 that was in the British Journal of Medicine. It was published there, and it basically showed that progesterone was not effective to treat PMS. But that was erroneous because the studies they used did not time the treatment with progesterone to the specific woman's cycle. Now that's completely ridiculous. Again, it goes back to the idea that, okay, people always ovulate on day 14, so therefore you start this progesterone, about just after that, basically, and they're going to be better. And that's not right, though. And it's basically using the mentality of the rhythm method, which is it's over 100 years old now, and like we want to move away from that system. It's unfortunate too. Like another thing holding us back is lots of our patients are very interested in technology, and that's really good as long as they kind of link up to something that is maybe predicting their patterns of periods and ovulation. And if they're using that information to predict when they're ovulating, that is also erroneous, because if it's only based on their periods, again, it goes right back to the rhythm method. Whereas women who chart their cycles with fertility care will actually really know when they're ovulating based on their particular cycle that time. It's much more accurate. So I'd love to get into the treatments, about how we actually do the treatments for this.
Yes, absolutely. I want women to know what it looks like. What does it look like?
So this is it. So very interestingly, we have a couple different ways of treating women in a cooperative manner, and one of them is simply to get we have different routes of progesterone that we can give to people. There's commercially available micronized progesterone that is actual progesterone. It's derived from yams, from very smart women and men pharmacists who make the actual progesterone molecule from a base structure of actual yams. Like this is fascinating. So they actually, like, so if you run that particular medicine through a mass spectrophotometer, that you're going to get the progesterone molecule, and it's going to match exactly to the human one, and that's so cool. So this is going to work cooperatively with the body. The body will recognize it as progesterone, and it's just going to add on to what the woman has. It's not going to make her make less, and that's the idea. Whereas, like, if a woman was taking birth control, it really tells the person's brain, you can stop making the hormones. It actually suppresses the LH, the luteinizing hormone that her body's making to help with the cyclicity of her cycle. So instead of promoting like a remote control idea, we're instead giving some hormones just a little bit extra, and that works great with this micronized progesterone. It's one that the woman would take during the time of treatment, just during the luteal phase. And even if the woman has some symptoms that go beyond her menses, or maybe start a little before ovulation, it's still the same treatment. And we find that very, very effective. And usually with continued treatment, it gets better and better. So that would be like an oral route, and that way it'll affect their, it'll feel good to their brains, it'll feel good to their ovaries. And this micronized progesterone actually does get through the body very well. We've shown with studies at the Pope Paul VI Institute that if we used IM progesterone that is intramuscular, that would also work very well. And the vaginal progesterone doesn't typically get around the whole body as well, so I prefer to use the oral. And it's so simple because it doesn't require nurse administration. That's really great. The other treatment is actually giving a medicine called human chorionic gonadotropin, and typically HCG, the human pregnancy hormone, is actually basically given for a couple different reasons in gynecology. And one is to help people ovulate. We can give little small doses, but that's not the way to treat PMS usually. The other thing we can do is we can help give sort of a trigger shot to help with ovulation right at the time of ovulation for some women. And that's very popular among OB-GYNs. They know that if they give a large dose, like 10,000 units of HCG, it'll help with ovulation typically. But with PMS, and to help support the luteal phase, we actually give it after ovulation. And this is really neat. We can give a dose of about 2,000 units on peak plus 3, 5, 7, and 9. And that will actually mimic luteinizing hormone, which is somewhat deficient in our patients with PMS. And it will actually tell the body to make its own progesterone and estrogen at the right doses. And this is so cool, because the HCG is 5 times stronger a signal than luteinizing hormone. And that makes sense. If a little baby was growing and the early placenta was giving a signal to the mother, hey, I'm here, please keep making progesterone, it makes the HCG, and then the woman makes more progesterone and keeps the pregnancy there instead of having a period. And this is the same thing, but the woman doesn't get symptoms of pregnancy while they're taking their HCG. I've had literally maybe 3 patients say that they had a little bit of nausea with the medication. HCG is just a little more complicated because it's given as a shot, but we can give it now as a subcutaneous injection, and that really, really works well. There's some people who have tried different routes of HCG. I have some friends who are pharmacists who can compound under the tongue version. I haven't had the greatest experience with that, and I can't say that it to that one way or the other yet. But the HCG shots as a subcutaneous injection, they're so simple to give. The woman can give it to herself. You could also give it as intramuscular injection. Probably her partner would have to give that, or a friend. But the shots are actually even more effective than the oral progesterone. So it's really great. It's also one of the best therapies for a particular type of luteal phase dysfunction, where the woman produces a little bit of progesterone that's pretty good, but then it drops really rapidly. In those cases, I get really concerned when I see that kind of luteal phase analysis, because that particular woman is very much at risk for recurrent miscarriage.
Okay.
If we treat them with the HCG, however, it's almost virtually eliminated. And, as you said, my mentor, Dr. Hildress, he really loves to treat women from miscarriages and help them avoid them. And I've seen him give this talk several times, and he would often get verklempt about the I wish we could treat all women, for recurrent miscarriage with this drug, because it seems to work so well.
Right.
It's not always the cure, but in this particular problem, it is so great. So you kind of get a double treatment there, and certainly for anybody who, if they were using progesterone and that was working great for their PMS, if I knew that their luteal phase had this kind of particular type 1 luteal phase deficiency, and especially if they had even in their charting alone, it shows when a woman has 8 days or less for their post-peak days, we want to treat them with the HCG when it's time to get pregnant, because that's going to be the better treatment than the progesterone alone. It's pretty interesting. That's awesome.
This is also fascinating. And so what you're saying is that in the treatment of PMS, there's not a one size fits all. It's really understanding, first, validating the woman that she is coming to you with a struggle. And it's not something made up in her head, but it is a real struggle. But it's not the same struggle as another woman experiencing PMS. There may be commonalities in the root cause, but you're going to get to her specific reason for experiencing PMS and then come up with a very individualized and customized solution to optimize her health.
That's exactly right. And also, we even have some complementary treatments that we can use too. A good example is a patient who came to me very early on. I mean, this shows the need for naprotechnology doctors. When I was in residency, I knew I wanted to really help start at a place where maybe people weren't quite receiving all the naprotechnology, or where I could be most useful. And starting this office in Austin was really special. And I had patients actually contacting me while I was in residency, before we even opened up the office, to get an appointment. And one of those patients was one with some severe PMS. She had already been treated a little bit by her psychiatrist with, I think she was taking some Prozac at the time, but it was moderately helping out. But she still felt rage, actually, when she got into her luteal phase, and she was charting perfectly. She also was taking, she had started taking some Optivite, which is a vitamin that's very popular, and this kind of grew in popularity around in the 1990s, after Marilyn Shannon wrote that book, Cycles and Fertility. It basically, I forgot the name of the book exactly, but she's a great author. And
okay, I'll have to get the name of that book.
She's talking about PMS.
Optivite, yes.
Yeah, Optivite is amazing, and it's interesting. It's not a very good prenatal hormone, because it doesn't have folic acid. You'd have to take extra folic acid to really cover a prenatal with that. And you do have to take 6 pills a day, and it seems kind of funny, but people actually, when they take it, they feel particularly well. So that's great, and it's easy. It's not too hard to do, and it's not crazy expensive either. Yeah. So that could certainly be something that people do. Other prenatals and multivitamins might be helpful. And certainly looking at nutrition again. We are what we eat, so you gotta take care of yourself. But anyway, I assessed this woman who was still feeling trouble even though she had the Prozac, and we did her analysis of hormones. She was definitely deficient. We gave her the HCG, and she said it was like a whole new world opened up. It cleared almost all of her symptoms dramatically, and she could be free to be the busy mom that she was. That's really, it was great for me. Just starting off in practice, she was like my third patient, and literally in the door, and she was so happy, and then it just spread from there as far as our popularity as an office and stuff.
What a beautiful story. That is a beautiful story in this work that you're doing. And that's the goal of the summit. We know that you are a busy doctor. You are treating women day in and day out, and we want to help get this message out there. Now, Dr. Kalamarides, I'd like to switch gears a little bit, because as we are recording this interview this week, the FDA just announced the approval of a new drug for the treatment of postpartum depression. And I was reading up on this, and it looks like the drug mimics progesterone. And that's what we have been talking about in our time together. And we know the link between progesterone and psychological health. So I would really like to get your opinion on this new drug that is a potential treatment for postpartum depression.
Yeah. Actually, it's quite exciting that the FDA is focusing on this drug and that this drug was produced, because I'm really glad that so much of women's science has been just thwarted by contraception for years. I mean, like literally 40 years of work on understanding women's cycles of fertility and infertility, of all kinds of women's health issues, have been just like kind of swamped because there was all this focus on contraception, which is suppressive, versus being cooperative and really working with women's cycles. But now this is great. We've got focus on needs, like postpartum depression is really being talked a lot about. We also have more talk about endometriosis and saying, you know what, don't ignore that woman with the pelvic pain. Get her into surgery, take a look and see if it's really there, treat it. But back to this postpartum depression, it's very interesting. There's been a lot of focus on the OB world, where we have to recognize like these women are particularly in danger, and they're in danger of harming themselves. They may have continued depression for a very long time if it's not recognized, and this can really affect their families. It can affect their babies and their relationships. So I'm really happy that we're doing that. On this new drug, the brexanolone, it does mimic some progesterone in some ways. So it's really very much like pregnenolone, which is a progesterone derivative, and it's naturally occurring in our bodies. It basically, the brexanolone has to be given IV, and there are some concerns from the FDA that this medication can cause a loss of consciousness for about 3% of women who are receiving it. So it has to be monitored extremely carefully while being given. And I think even after it's been given, they're talking about, well, since it's being given IV, it has to be given in an IV infusion center or a hospital. And that, unfortunately, is kind of not very practical for busy women who really need a treatment that's going to work for them to help relieve their real depressive symptoms during this very important time where they need to be bonding with their baby. They have all kinds of expectations of how things are supposed to go. We need them to be learning that breastfeeding is a possibility, that bonding with their baby is so important. And anyway, so brexanolone, this is great. I mean, it's a good new drug, but in NAPRO technology, we've been using progesterone for quite some time. And actually, we've had very good success with this. It's not necessarily FDA approved for this, but it's certainly a viable treatment in combination with treatments such as antidepressants and real treatments and close monitoring of the patient. And again, as we were kind of talking about PMS, it's kind of multifactorial what's going on. We have to really embrace the patient, tell them when we identify postpartum depression, which we're very, very careful to look for nowadays, right away, like after someone has a baby, it could be women might go through kind of the baby blues for about 2 weeks, and some of that might be normal, but we really want to be on alert for depressive symptoms and anxiety that continues after that time, because that is not normal. And depending on how severe those symptoms are, we might get to treat them earlier. We have many screens for the patients now. We should really be screening at 2 weeks postpartum, and then definitely at the 6-week visit postpartum for depression and anxiety symptoms. But actually, my hospital is really awesome in that the nurses who were taking care of the patients in the postpartum area actually give a checkup call to the patient and ask how they're doing. And if they have symptoms that come up that alert the patient or alert the nurse that the patient might be having some postpartum depression, they'll actually send out an alert to us as the physician so that we can go ahead and get that patient in and treat them early.
Mm-hmm.
And then we're talking about also getting everybody involved. We have to get the partner of the patient involved if they have one. If they don't, we need to get their supportive family involved and help them to know, this isn't something, it's not the patient's fault. In fact, the patient's a hero for admitting that they're having those symptoms. And we want to get them treatment that's real and effective.
Absolutely. Yeah, this is so very beautiful. And when I read this article about this new drug, I immediately I thought about NAPRO technology, and I have countless stories of women who were on the floor, unable to move after delivering a baby, went in for intramuscular progesterone injections, and within 3 days they were back up and functioning and doing well.
It's amazing. So that in NAPRO technology, typically the first treatment is actually an intramuscular injection of progesterone. Sometimes even like within that day, they're feeling better.
Mm-hmm.
And we do close follow-up with them to make sure they're all right. We might give several shots of the progesterone after a woman experiences this. Some doctors will also give the oral progesterone. Mostly, it's talked about in our studies, we find that the progesterone injection of a shot is probably more effective. We do have to tell them that they might experience some drowsiness, especially with the oral medications, and to watch for that. But we haven't had loss of consciousness. That's not going on.
Right.
So in a way, we've already got something that's a little safer. We're going to follow them very closely. We always have to be on alert if a patient could have suicidal tendencies or ideation. And also if she's feeling about sometimes patients actually feel like they want to harm somebody else when they're experiencing these postpartum symptoms. And of course we have to be on alert for that and then treat them appropriately if we need to. Sometimes we have to get other professionals involved too. It's not always on the OBs or the family practice doctors. We have to be aware that we have these other tools and partners, and getting a psychiatrist involved in cases of severe depression is a really good idea in addition to the NAPRO technology. So it's totally fine to do that, and they might actually be excited about how well this treatment actually works.
Yes.
So
yeah, we absolutely need to get this information out to the public. And I think that we could probably talk on this topic all day long. It is so very important. And for the first time in, I think, many, many years, we're recognizing PMS as an actual medical condition. It's not something that's just in a woman's head or something that she just needs to grin and bear, but she deserves to be recognized in her struggles and then to receive treatment so that she can optimize her health. So, Dr. Kalamarides, as we are conducting all of these incredible conversations in the Cycle Power Summit, we are asking all of our experts to share with us and with our listeners their number one cycle power tip. So, if we could close with your number one tip of advice for women who are listening.
Okay, I guess it would be, as a former, I'm not teaching fertility care right now, but certainly as a certified fertility care medical consultant, and my wife is the fertility care practitioner in our office. We have other great fertility care professionals around town, and who often will send patients to us. I really want to tell people, keep charting every day. Keep charting with the fertility care. Write down your symptoms. Don't give up. If you observe correctly every day and you're writing down those symptoms, you'll know your body so well, and always impress doctors and who you come to. If you have any kind of problems, they will be amazed at your knowledge, and if you're doing it correctly like that, it's just so impressive to everybody. But also, you're going to be taking care of yourself in the best way, and really having a great fertility record. So don't stop. Just keep charting.
Oh, absolutely. I could not agree more. Such fabulous advice. It really is about adopting a charting lifestyle. And once you know how to chart well, it really does transform the outlook that you have on your body. I really am a believer that it builds a positive self-awareness and self-acceptance. So even when our body's not doing what we want it to do, we're a little more forgiving and we're able to get the help that we need.
That's exactly right.
Dr. Kalamarides, this has been a fantastic conversation. I cannot thank you enough for taking time out of your busy schedule to be with us today.
Thank you so much. It was a great pleasure.
All right. Thank you so much. And we will be in touch soon. Bye for now.